Right. Good morning, everyone. Thank you for joining us on this wonderful Saturday morning, bright and early. Welcome to the South African Clinicians Leadership Forum. We're excited to have you joining us today and participating in this meaningful dialogue and research leadership. We look forward to hearing your thoughts, your perspectives, and to garner the experience and expertise of our esteemed panelists. So we're going to get the program going. We'd like to thank the South African Clinician Society, Scientist Society, Discovery Foundation, and the UCT Clinician Scientist Society for hosting this session. And we're going to kick off straight by introducing our first speaker, who is Professor Salome Maswime. She is the president of the South African Clinician Scientist Society. So without further ado, Prof, please go ahead and give us your welcoming address.
Thank you so much, Chair. I want to welcome all of you and to thank you for joining us this morning on behalf of the South African Clinician Scientist Society. 4 years ago, when we launched the society, our vision was to create a network of clinician scientists who would become global leaders and transform healthcare in Africa through translational research. I had been asking myself for a long time, why are people dying from preventable diseases despite all the advances in science and healthcare internationally? Whilst many of us belong to professional societies in our clinical disciplines, we felt that there was a need for us to have a scientific society for clinicians where we could recognize excellence through the South African Health Excellence Awards, provide platforms for sharing knowledge, such as the South African Clinician Scientists Conference, and to create opportunities for research and leadership training and advocacy through webinars and seminars like this. Many of us were at the beginning of our academic careers then, some starting, some completing their PhDs. But the common thread we had amongst us was the inevitable leadership trajectory that came with being a clinician scientist. I have proudly lost count of the number of promotions we have seen amongst us in the past 5 years. Promotions to heads of clinical units, heads of divisions, heads of departments, directors of NGOs, and professors. So one can ask, is the clinician scientist destined for leadership, or is the clinician scientist a natural leader waiting for an opportunity to lead? Regardless of the DNA of the clinician scientist, the reality is that many of us will be required to take up leadership roles sooner or later because our country and our continent needs us. And it often happens even before we are ready, before we have even refined our research and clinical skills. Often a very hard decision to make, whether to harness our research skills or to take up the call of leadership. Whilst our medical training prepares us to become great clinicians, our postgraduate degrees prepare us to become good scientists, but nothing really seems to prepare us to be good leaders, except for the assumption that we're already leaders when we finish specializing. I painfully realized that for most of my career, I wasn't leading anything or anyone. the only person I was probably leading was myself. It was only when I started handling budgets and had to deal with human resource issues and administration that I knew I was now truly in leadership, where the dynamics of how I related with each member of the team would either break or make the organization. And when I had to start engaging in conflict resolution and management decisions and developing visions and strategies and SOPs and reports. Getting a leadership position is often the easier part, but becoming a good leader is the difficult part. Accountability is now becoming an important theme in healthcare in South Africa, where many of us have realized that there are no real platforms for us to question, confront, or even report poor leadership. What happens when a hospital perpetually has bad patient outcomes? What happens when a department has never produced one Black specialist, PhD, head of department, or a professor? What happens when patients continuously experience abuse at the health of health workers? My hope is that we become the next generation of health leaders that will not be leaders who lead through fear, intimidation, and bullying, that we will not be leaders who deny those who we are leading opportunities to grow and develop and become better than us. Our country desperately needs leaders who are both innovative and compassionate, who are not afraid of developing new interventions and new ways of delivering healthcare services. Leaders that will create a health system that we can all be proud of, rather than one that we are both afraid of using as clinicians and patients. Everything rises and falls on leadership. We may be great clinicians and great scientists, but to improve healthcare in our country, we need to become great leaders. I invite you all to participate today and enjoy our first leadership forum, where we hope to have challenging and inspiring conversations about research and academic leadership. We have a phenomenal lineup of speakers, leaders who are both inspirational and who have also been selfless in many ways throughout their journey. I want to thank the Discovery Foundation and the UCT Clinician Scientist Society for co-hosting this event with us. This meeting would not have been possible without you. So I will close with the quote which says, if your actions inspire others to dream more, learn more, and become more, then you are a leader. Thank you. Enkosi Galebo.
Thank you, Prof. Maswime, for that wonderful welcome address. Very excited to listen to the views of all our panelists and our guests. I think we're going to move on to Prof. Maphai. I'll just allow for a quick introduction. Colleagues, he is Professor Vincent Maphai is a distinguished professor whose career in academia spans both in private and public service. He is currently the board chair of Tivani Stillwater, the Discovery Foundation, Discovery Insure, Discovery Life and Invest, as well as Stadio Holdings. His lifetime work spans from being a director at South African Breweries Limited, BHP Billiton, and he's also had some time being a professor extraordinaire, Department of Political Science, and the University of South Africa. He held a fellowship at Harvard University, Princeton University, Stanford University, and he also serves as a research executive director of social dynamics at the HSRC for 3 years. Welcome, Prof. Maphai. Please go ahead and give us your address. Thank you.
Thanks very much, Seho, and good morning, colleagues. I'm sitting in a car. It's pouring out here, but it's nice and warm. I'm in the Southern Cape, and I'm very delighted to be joining you this Saturday. When I was invited to join your conference, I was pretty intimidated wondering what I would ever say to such an illustrious group of people. But fortunately, whether by deliberately or by accident, I was helped by two people to decide on what I would like to talk about. One was Professor Musa. He gave a talk 2 weeks ago, and he emphasized an important thing, that the university, the medical school trained him for technical aspects of his work, but not for the context and the systems in which operates. The other one was from Professor Salome, and she continued on that trajectory in her remarks a few minutes ago about the importance of leadership. I'm not going to talk about the theory of leadership, but I'm going to make a few remarks about it, about how fundamental leadership is. A theory of leadership itself is very simple, maybe not easy, but very simple to crystallize in simple language. A leader has to get 4 things right. 1, there has to be clear direction of where you are taking the organization. By you, I don't mean you personally, you and people around you. Clarity of direction. The second thing is the ability to put together a team of people who can deliver on that mission. I wish I could speak on the second one for the rest of the meeting, but I'm not. And the third thing is to support that team. Don't give people a task, but you don't give them the tools to do the task. And lastly, hold the team accountable. If you are not delivering, you must go. It is as simple as that. If you don't believe it, you must watch many sports. I watch rugby and soccer. At one point, if you are the missing link, they bring in a new link. Or if you are tired, you are getting replaced. But that's a subject for another day when you're bored and you don't know what to do with your time. We can elaborate on that. I want to go back to the question of systems and context. And one of the things that really strike me is how we South Africans have short memories of a history. You know, I heard 2 or 3 days ago that Minister Pravin Gordhan has invited a member of Solidarity Union to come and help in the solution of ESCOM. 3 or 4 years ago, I remember Minister Pravin saying he wants to import Italian engineers to come and help with ESCOM. And yet the engineers were at home. They wouldn't need passports to come and help. And it's a bit of something that we South Africans have a weakness in, ignoring our own resources, forgetting what got us out of a mess, and taking us forward. And I want to spend the rest of those minutes dealing with these 2 issues, not in theory, not in detail, but saying these are the key lessons they give to us, namely understanding your context and namely understanding the importance of leadership. As a country, we are very dispirited at the moment. Things are not bright at all. We are discouraged. We wonder where we are going as a country. I suspect in this audience today, there must be people who were at least above 16 in 1989. If you are in your 20s, it's even better. December 1989, we were preparing for a civil war in this country. P.W. Botha had run out of ideas. The townships were burning. The ANC was not able to overthrow the government. And everything was in a mess. we were preparing for civil war, and people were beginning to stockpile. I want to leave it there. I'll come back to that theme. How were we able to prevent that to happen? I think the issues I'm going to raise now are precisely the issues we need to address today, because we managed to prevent that civil war. Otherwise, Salome, you wouldn't even be around if that civil war had gone ahead. And let us look at what helped us from preventing the civil war. And I'm going to suggest that this is what we need today to get out of the mess in which we are. The first thing that got us out of the mess was the realization that we were at the point where we couldn't produce winners, but we could only produce losers. We were in a stalemate. We were unable to unsettle each other. We are unable to replace each other, but we had the capability to make life hell for each other. 2, we had the wisdom to realize that. We realized it. 3, we engaged. That was what Codesa was all about. Once we realized that we couldn't push each other around, we went into a negotiation program. And one culture to which we need to return immediately that was produced by the negotiation system was we realized that a zero-sum situation is horrible. You cannot operate in an environment which says, I want to win, but on condition you lose. Because that kind of attitude leads to mutual destruction. And there's a bit of that today. But once you get out of a zero-sum game, you enter a culture of accommodation. I may not like to everything you are doing, but I will live with it, considering the greater good that comes out of it. Many of relationships, whether between friends, whether between lovers, between partners, between everything, it's always based on accommodation, because you realize nobody is an angel. And that kind of view should be organic, where you realize no group is an angel, that the mess we are in is not between the angels and the devils, but that all of us are contributing to the problem, and we can similarly contribute to the solution. There was another thing that helped us avoid civil war. It was very, very active civil society. Very, very active civil society. People were either on strike or were talking to each other. But we reached a point where we said we can no longer leave this only to politicians. That was a very, very important point we made. And lastly, Salome, I hadn't forgotten you. We had strong leadership. You see, when we talk of leadership around that time, we always think of Madiba. But I think we always forget that it takes two to a tango. And somebody we don't talk about positively because it's the worst thing you can do. And the only reason I'm talking about it is you are too far to throw a cup of hot coffee at my face. It took a combination of Mandela and de Klerk to save the country. Mandela would never have done it on his own. De Klerk would never have done it on his own. And what is the credit I personally give to both of them? They had the moral courage to say, listen, we have to create a new system. And if you notice, both of them became unpopular in their constituencies. The poor expected Mandela to give us AK-47s. Afrikaners particularly expect de Klerk to make apartheid even harder than it was. And both of them had the moral courage to send unpopular messages to their constituencies. Those of you who remember the death of Chris Hani, That was the day Mandela became president. He stood up, went to SAB studios, and told us South Africans that we are in a crisis. A popular leader has died. But his last words were very prophetic. He said, but we found a murderer. And finding that murderer was facilitated by a fellow South African, white, Afrikaner, and female. Now, what was interesting, the audience expected to say, Mandela says, I'm angry, I'm bringing you AK-47 for revenge tomorrow. What did de Klerk do? When people wanted him to smash everybody, he said, I'm releasing Mandela. I can talk a lot on that issues. I just want us to take a pause because my time is very short. I think I've already used my 5 minutes. To say, where are we today? I'm saying exactly where we were in 1989. What is missing in the country? We are missing serious political leadership. Let me put it bluntly. We have absolutely no political leadership in this country. Politically, we are rudderless. Politically, we don't know where we are going. Politically, there's no leader, both in government and in the opposition, who stands up inspiring to say, I know if I follow this person, I'm going to get somewhere. What else is missing? It's you and me, civil society. We are missing in action. There are no Bishop Tutus. There are no Dr. Motlanas. Ordinary people who in the 80s and 90s were in the streets leading us, reminding politicians that we own the country, not them. And that if they don't follow us, we know what we are going to do. That is precisely what is missing. We have gone back to the zero-sum game. People with racist mentality, both black and white, can flourish and get away with it. And so, as I wrap up, I'm saying our solutions are not very, very difficult to find. One, we need leadership. And this is where all of you come in. Salome touched it, but because of limited time, she did not expand on it. And I think this is also what Professor Musa was complaining about. We forget that the primary function of universities is to produce leaders, not technicians. Universities are there to produce leaders. I remember spending some time with Minister Pando. She had just thrown out a few vice chancellors out of her office. She said, you know, Vincent, I thought we were paying universities to solve our problems. But these vice chancellors came to talk to me about their problems and I kicked them out. I said, guys, go and do your work. Bring me solutions, not problems. And I think this is where all of us are as professionals. We are excellent at becoming a gripe with gripe sessions. And we have forgotten that we are part of the problem and part of the solution. That's where I think universities can go back to the drawing board, not just in your field, but everywhere, that universities need to ask themselves, are we producing leaders? The very fact that we have no political leadership today, it's a serious, serious indictment to universities because their primary function is to produce leaders, not technicians. The second thing is us as civil society. I think we are at the point as civil society, and when you go about, you get that feeling very, very strongly coming up, that as civil society, we need to go back to politicians to say there's a contract between you and us. Your job is to provide us with security, and your job is to provide us with a certain minimum of services, and our job is to pay taxes. If we don't pay taxes, we get locked up. But if you are not doing your job, you don't get locked up. Can we renegotiate what we are doing now? And I think this country, from what I've said, especially look between now and December, is going to be the most critical part of the country, because I have no doubt Professor Ramaphosa will be lucky to last even till end of September. I think he will be lucky, but definitely by December, he won't be here. I think the issues around him are very, very serious, very, very compelling. And for me, I gave up. If you look at the simple questions that the public protector put to him, if he was innocent, he should have answered them in 5 minutes, or at least in 1 day, because they are not complicated questions. They don't require answers. They just require a yes and no. And if he goes, we are going to enter into a political vacuum. And you know what happens? When you are in a political vacuum, the only people who have the capacity to close that space are criminals. Criminals know how to close the loop. And ironically, if we as civil society, if we as university professors, if we as university administrators were very serious, we should have already been contemplating, when this vacuum comes, what are we going to do? Have I given up on the country? No. I think we are going to go into a very, very serious crisis. But that crisis is not insoluble. What we need to do is take a step back, look at how Mandela and de Klerk dealt with a crisis. We don't need a PhD on that. Once we do that, we are going to get worse. We are going to get well. We were in the brink of collapse. We survived. And I'm absolutely sure January next year, we will have survived or even got better than what we were before. But it's going to require a lot of innovation, a lot of courage, and a lot of commitment from everybody here in the meeting today and beyond. My time has come. I wish you everything of the best for the rest of the day and for the rest of the weekend. And my greatest solace is to see the number of young leaders in front of me today. Some of you are young enough to be my grandchildren, and it makes me very proud that the country is going to be in your hands. Good luck. Thank you.
Thank you very, very much. That was incredible. Thank you, Prof. Maphai. We appreciate your thoughts, as well as your perspective regarding where we are and where we need to go. Really, really inspiring. Thank you. Without further ado, we're going to go straight to our keynote speaker, and allow me to introduce Professor Sir Tumani Corrah, who is the Executive Director of the Emeritus Director of the Medical Research Council Unit, the Gambia at the London School of Hygiene and Tropical Medicine. He's the founder and president of the Africa Research Excellence Fund, established 6 years ago. This fund focuses on talented emerging health researchers in the continent, providing them with stepping stones to a successful research career in Africa for Africa. Welcome, Professor Corrah. You're welcome to proceed with your presentation. We look forward to it.
Thank you, Salome. Good morning, everybody. First of all, apologies for joining you late. I had some technical problems with my computer. And the technical problems actually started yesterday. And I've kindly asked the organizers to share my slides on my behalf. And now this technical problem continues. Light has just gone off. I hope you can hear me.
Yes, we can.
Okay.
Yes, we can.
Thank you very much. First slide, please.
We can see it. Can you see it?
No, I can't. This is a big problem with my...
So next slide.
It's okay. I think I know what's in the slides, and I should be able to proceed as you. I'm opening windows and doors and everything now. Thank you. Chair, okay, it's okay. Let me go ahead. Let me stop wasting time. Chairperson, Professor Salome and RF alumni, of whom we are very, very proud of you. Please allow me through you to thank the organizing committee for giving me the opportunity to deliver the keynote address at this year's South African Clinician Leaders Forum. I am deeply honored and privileged, and I dedicate this talk to my late friend and colleague, the late Professor Bongani Mayusi, gone but forever green in our hearts. I do certainly miss a sounding board. He was involved, I engaged him when I tried to create the Africa Research Excellence Fund, and his contributions were significant. May his gentle soul rest in peace. The two chosen panel discussions are really timely. Research leadership and research to policy, and remain significant challenges. Congratulations on choosing both. Next slide, please. I agree with my friend John Kengasong, former director of the Africa. Okay, I mean, this slide shows you exactly what research in Africa was like, what leadership in African research was like. And I thank God that today, if you went to any research institutions in Africa, there are significant numbers of Africans in significant senior positions. Next slide, please. I agree with John Kengasong, former director of the Africa Centers for Disease Control, who now leads PEPFAR, that public health in Africa is a story of neglect and dependency. For me, it remains in coma and requires urgent resuscitation. As John succinctly puts it, a new beginning is called for. African governments and Africans must stand up and face the daunting challenge. Excellent research leadership and effective translation of research findings into policy are requisite cornerstones to improving health and saving lives. This is exactly why I founded RF 6 years ago. Between the years 1950 and 2018, Africa's population increased from 100 million to 1.25 billion and could rise to 6 billion in the next 100 years. Such massive increase in population growth, continuing deforestation, climate change, and increasing air travel are recipes for disaster with significant potential to further increase the disease burden in the African continent. Thus, the future of Africa, the future of health in Africa is bleak and does call for urgent attention. Next slide, please. Many challenges persist. Despite millions upon millions of dollars having been spent on research, career development, and on research, our beautiful and rich continent remains home to 17% of the world's population. Yet we host up to 25% of the global burden of disease and 95% of global malaria cases. Regrettably, our publication output is not increasing. As earlier in 2020, a decade after the publication in the Economist Journal, the BMJ revealed that Africans are responsible for the publication of 3% of the highly topical coronavirus infection papers. A decade ago, may I remind you all, it was reported to be rising, but it was only 2.4% for a population of 17%. In 2018, in a ranking of global scientists based on the citation index, ranking best scientists in medicine engineering, Clarivate Analytics revealed that only 15 out of 6,040 scientists and researchers globally were from Africa, 10 from South Africa, and may I quickly add that it doesn't necessarily mean that these were national South African scientists. 3 from Egypt and 1 each from Nigeria and Kenya. The continent can and should and must do better. Next slide, please. The state of our health systems in Africa is unacceptable, under-resourced, and cannot cope with the high disease burden. This results in physicians witnessing daily preventable and untimely deaths. Our research systems are weak, well-funded research careers are rare and only in a few institutions, and sadly, non-existent in most. There is an unacceptable shortage of national funding to support healthcare and research. A report on health capacity strengthening commissioned by the UK's Medical Research Council highlighted gaps in funding postgraduate training. Whilst there is huge funding for PhDs and MScs, which are on the increase, there is scarce and limited resources funding for postdoctoral training in Africa. Fully funded postdoctoral positions are rare. Our postdocs are usually fully engaged in other people's projects. This extreme shortage, or at times absence of postdoctoral positions, and the lack of established career research fellowships spells a bleak future for research capacity strengthening in the continent. The continent thrives on an extractive economy. Farmers labor and toil under extreme heat and heavy rains to produce cocoa, only to export them relatively cheaply. And Africa then joins the rest of the world to purchase super delicious, but truly expensive chocolates. Likewise, we export our crude oil and buy back the finished products, petrol, diesel, and lubricants. It will appear to me that we do not seem to know much or anything about added value. And I often ask myself the question, why? Just why? Next slide, please. We must not let this happen to our science. We have the diseases, the samples, the data, and we also have talented individuals. Africa must learn to exploit this to the benefit of our nations and for global health. To achieve this, Africa's talented emerging health researchers require the knowledge and skills to ask compelling research questions, the ability to design their own research, the skills to collect their own data and samples, and the competence to analyze and interpret these. Only in this way can they grow to become established and independent health researchers with international recognition. Your topic, therefore, research leadership is truly timely. This is indeed lacking. The required skills and ability to convert a research idea into an attractive, fundable research project is key to a successful research career. The story must be persuasive to arouse interest from panels and funders. These skills put together with a rigorous research design and plan, and the competency to deliver on projects are useful tools for winning a grant. And together with skill supervision and good leadership, added to this added knowledge of associated soft skills and available funding, a new researcher or an emerging researcher can enjoy a successful career in research in Africa. Next slide. RF was founded just for this, to improve the quality and impact of health research by Africa in Africa. It remains a challenge that none of the top 10 leading health research institutions in Africa, perhaps outside South Africa, is African-owned. Rather, they are owned and funded by the Institute Pasteur, the Wellcome Trust, the UK Medical Research Council, the CDC, the NIH listing but a few. Today, with the growing numbers of PhDs and research clinicians in Africa, this time is right to grow our own talent to enable them become future globally recognized research leaders, improving health and saving lives in Africa and the rest of the world. After all, China and India have done just that. Why not Africa, I ask? The current status quo in Africa is not a sine qua non. It takes innovation, good leadership, and commitment for African continent to become a powerhouse, generating scientific knowledge to improve the health of our people. To me, this goal is achievable. Next slide, please. RF is a charity that has identified a niche. And this is the postdoctoral, the early postdoctoral phase. When our early postdoctoral and clinician scientists longing to become researchers and scientists become disillusioned due to lack of funding, particularly national research funding. They are left with few choices: emigrate to greener pastures, almost certainly never to return, or join well-paying NGOs or work on other people's research projects full-time. The few who choose the latter path, though loaded with additional teaching responsibilities, must still acquire the required knowledge and soft skills to win competitive international research funding so as to survive a research career. Next slide, please. Key drivers for this to happen are to identify talent only through a competitive process, then develop and retain them to improve health and save lives in Africa. The ability to win their own research funding remains key. Not much need to go elsewhere for these young aspiring scientists if their vision and mission are readily available at home. The RF fellows so far are staying put in our continent. Next slide, please. RF, the Africa Research Excellence Fund, is at home on the ground in Africa for Africa. We appreciate, next slide, please. We appreciate and understand what our aspiring researchers need. Our programs are transformational and are all created in 3 stages. Next slide, please. Next slide, please. We focus on early postdoctoral clinician researchers and also focus on African research institutions. After a consultative process, we identify the needs of our beneficiaries. We then developed a program and followed this by the development of an appropriate evaluation plan. Next slide, please. Next slide, please. Next slide, please. At RF, we run 2 programs, our competitive RF programs and our academic programs. Our competitive award programs provides researcher opportunities and our researcher development fellowships. With the EDCTP, we successfully ran additional fellowship awards for 2 years. Our academic programs focuses on researcher development and includes our popular essential grants writing and peer review workshops and our exemplary researcher and leadership development programs. For early outcomes, we look for the development of new skills, new networks, collaborations with others, and numbers of proposals submitted for funding. Whilst for longer term outcomes, we see competitiveness for funding, publications in high impact journals, career advancement, promotions that is, self-esteem, leadership, influence, and impact. The RF grant writing skills workshop programs are designed to support researchers in Africa to compete successfully for funding. Our programs are interactive and designed so that researchers are utilizing skills as they are developing them to provide drafts of work which are honed in throughout the course, resulting in substantial work being completed towards an application. Time is spent on professional development plan, that is how to prepare one, identify what professional skills they already have, and what new skills are indeed required to achieve their goals. We focus on how to ask a research question, planning and budgeting, what to ask for and what not to ask for. We run mock interviews, mock peer reviews to learn about what funders are particular about. Run some ethics courses on how to prepare a convincing and well-structured write-up. For our researcher development fellowships, we believe in exposing our emerging talents to the culture of excellence at an institution in Africa or Europe. Institutions familiar with successful grant applications. As an example, exposing an early epidemiology postdoc to the London School of Hygiene and Tropical Medicine provides the unique opportunity to network with other students from different parts of the globe. Opportunity to attend stellar workshops and enjoy the experience of a world-renowned institution. They acquire new skills, develop new collaborations, form new networks, and acquire new knowledge and ideas. The fellow enjoys the privilege of a dedicated sponsor to guide him or her to personal research programs, leaving the school with well-advanced grant applications to welcome trust to CDC and also to the MRC and other funders and national funding institutions. This researcher leadership development program, next slide. Our researcher leadership development program equips the researcher with the knowledge, skills, behaviors essential for healthy careers and research leadership roles. The program provides for individuals as well as organizational development. Each institution is represented by fellows and an institutional lead. The role of the institutional lead being to act as the link to the institutional hierarchy responsible and is responsible to cascade new knowledge into the institution. RF Leadership Development Program is a comprehensive suite of workshops designed especially for the research context. Together, the program covers individual leadership qualities, team, institution, and disciplinary leadership, strategies and skills necessary for larger scale impact and innovation. The comprehensive program includes several courses. First of all, the effective research, how to become the effective research leader. This course develops the individual leadership style, skills, empowering and enabling researchers to be more effective in leading their research and proactive in developing themselves as research leaders. It also includes the influential and inspiring research leader and how to become one. This course develops the researcher's leadership ability within the context of research teams, institution, and their specific disciplines. It also includes the engaging and impactful research leader, how to become one. We all know that increasingly being a research leader means engaging and influencing across traditional boundaries of discipline, nation, and sector. This course is designed to support the development of skills and understanding necessary for researchers to successfully engage and collaborate with a wide range of people, as well as to lead innovation and change in areas related to their research. RF supports institutional capacity, and to implement and embed Excel learning into practice, RF supports home institutions as they seek to strengthen their research capacity through systematically developing their research talent. We work with institutions on their identified priority and together develop a project and action plan, which is thereafter integrated in institution. This is RF's contribution to researcher leadership development. Next slide, please. I think it is right at this stage to express my views on who a research leader is. And I make reference to the Vitae in Manchester, who are well-recognized research leadership and in general leadership providers worldwide. Most certainly, not every head of department is a research leader. I am sorry. The research leader is someone who is exemplary. It's a nationally, globally recognized researcher, evidenced particularly by outputs in international peer-reviewed journals. Someone highly regarded by peers and colleagues. Someone who is excellent in inspiring his or her team and responsible for successfully producing a string of high flyers. Someone who is experienced in creating a sustainable team and experienced in developing staff and building collegial relationships within the team and beyond. Next slide, please. An excellent leader works continuously towards what is best for team and self, always placing team and team matters first. She understands that leadership is a learning process. The leader is fully committed towards improvement and development and recognizes when change is required and knows how to effect the change. It is not simply expertise in projects that makes a good research leader, although this is an absolute requirement. Next slide, please. An excellent research leader is always a good listener who believes in teamwork and always strives to make this better. She is a selfless individual who never gives up too easily. Is a decisive character with excellent communication skills. Can talk convincingly to a cleaner as well as the minister, a clergy, or a president. Now, next slide, please, and let's look at what leadership within our continent is. Our continent needs health researchers, clinicians, scientists, and all. Today, whilst over 70% of Europeans have received COVID vaccines, only 10% of Africans in Africa have. No African country has produced a COVID vaccine. This must remain the key reason for the low vaccine coverage rates in Africa. The initial vaccine shortages in India quickly became a thing of the past, as they now vaccinate millions a day with their own locally engineered vaccine. It is not just people and wealth that is required to discover new vaccines, as Cuba, a relatively poor country, has ably demonstrated. Leadership is key. Cuba may not be as rich as other nations, including some of the African states, but they do have scientific leadership, a quality which led to the successful production of a COVID vaccine. Chairperson, before the COVID pandemic, it took close to a decade or more for proven vaccines to reach the African continent. And at times, years for new drugs to be part of our treatment regimens. Whilst it is true, there are pockets of good clinical trial sites in our continent, there is a need to develop more state-of-the-art facilities with modern and well-equipped laboratories and with highly skilled and highly specialized staff, so as to speed up the introduction of new therapies and vaccines into Africa. Clinical trial sites and therapies and vaccines. Trials could then be run at the same time as they are run in the North, thus shortening the time for them to reach our shores. The proposal to build COVID production sites in Africa remains a joke to me. Building plants without developing the appropriate scientific skills and appropriate leadership is the same as building car assembly plants. It doesn't make a country provide its own Mercedes-Benz. On a closing note, I often wonder how many of our research discussions throughout Africa includes the Ministry of Finance. And how often do we ask our health ministries what their research priorities are? South Africa might well be an exception to the rule. I strongly believe that early involvement of these two institutions might ease the transition of research findings into policy and practice and enrich research funding from our governments. Next slide, please. I did a presentation to ARB a few months ago, and I read my summary of the meeting. To me, a leader must have empathy, the ability to walk in the shoes of others and feel what they feel. To me, arguably, this is the most important trait. Additionally, a leader must have a listening ear, must learn to share, must leave their doors open, help others develop, and ultimately be part of their joy. Bob Marley adequately puts it, he who knows it feels it more. Next slide, please. I take this opportunity to thank the organizers, and I take this opportunity to say, without appropriate, outstanding, excellent leadership, research and research capacity building will stall in Africa, and there'll be an ominous delay in transforming our health systems, making sure that Africans enjoy better health through which our economies might grow. I thank you all.
Thank you so much, Prof. Corrah. That was incredible. Thank you so much for the insight in identifying where additional resources and efforts can be made to support the research agenda for the continent. Colleagues, we now move to the second portion of our program, with our first panel discussion. This section is titled Research Leadership and will be moderated by Prof. Mpiko-Nseke. Prof is an MD PhD Muurberger, apologies, professor and chair of cardiology at the University of Cape Town. He's a former chair of the SA Heart Association Registry Program and the current director of the MyOC Research Group, the Division of Cardiology Clinic Research Unit, and has been a national principal investigator of numerous practice-changing RCTs. He's an established international clinical research leader of studies which focus on cardiovascular diseases that are prevalent in Africa and which aim to improve the cardiovascular health of the people of Africa. In recognition of his contribution to clinical research, Prof. Nseke is an elected fellow of the College of the Fellows of at UCT, member of the Academy of Sciences of South Africa, fellow of the American Academy of Cardiology, and he has been recognized for his scholarship by both the SAMRC and the NRF. You're welcome to take the moderating process forward. I will give you a reminder around 30 minutes so that you know where you are in the hour. Thank you, Prof. Nseke.
Okay, wonderful. Welcome, everybody. I want to start out by, again, congratulating and saying a big thanks to Prof. Corrah. That was amazing, very inspiring, and also to Maphai. Thank you so much. Lots of food for thought for this morning. And I think, of course, Professor Corrah's talk, as he indicated, fits right into this next session on research leadership. Before I introduce the sort of session theme, what I'd like to do is quickly introduce the panelists. I should say, because of limited time, we have about 50 minutes to go through the topic. I'm just going to introduce them mainly by title. Their detailed bios are available on links attached on the website and on the invitation for today, so you can look them up there. So let me start off by saying that we have 4 very inspiring, very exciting panelists, very well accomplished. We'll start out with Yanalisa Pulani. Yanalisa, you have your camera on, wonderful. She's the founding president of the UCT Clinician Society, Clinician Scientist Society. She's currently in the intercalated medical school, medical student program, doing an honors in the Neuroscience Institute in addition to her MB-CHB. And I should say that she was a major inspiration for the theme of today's research leadership discussion. So that's Yanalisa. We also have with us Prof. Palesa Motshabi-Chakane. She's head of Anaesthesia at the School of Clinical Medicine at Wits. I'm looking forward to engaging with her and hearing her thoughts on the various topics that come up. We also have with us, I don't see her camera on, Professor Tivani Mashamba-Thompson. She is the Deputy Dean of Research and Postgraduate Studies at the Faculty of Health Science, University of Pretoria. And then also I'll request camera to go on, and that's for Professor Lionel Green-Thompson, who's Dean of Faculty of Health Science here at University of Cape Town. Okay, lovely. Oh, right, so we're all ready to go. Okay, so I think I'm gonna go back a little bit and highlight a certain aspect of the talk we just heard, which will frame some of what we're just talking about. And what we heard there was, as Sub-Saharan Africa, we represent 17% of the global population. We unfortunately have between 25 and 30% of the global disease burden. We all recognize here that clinical research is absolutely indispensable to improving health systems, health outcomes at a national and continental level. It's indispensable to promoting equity and stimulating development. And yet, despite those figures, Africa represents only 2% of the world research output, as we heard. So there may be a number of reasons why this is true, but I think it's fair to say that chief amongst them is the dearth of the clinician scientists. There are very few in absolute numbers of clinicians who are interested and involved in clinical research. What we heard from Professor Corrah was how ARF is taking people who are already down that path and turning them into research leaders and to research champions. I think a big part of our problem has been the gap between our ability to train doctors and to train clinician researchers. So the question really for today, or the theme today, is what is the role of research leadership and us collectively as research leaders to address this as a problem? How do we define the problem? How do we think about the problem? What do we think the cause of the problem is? And ultimately, what are the solutions going to be? So that's going to be the theme of these 50 minutes and the challenge to us collectively as research leaders and to the panel. So I'm going to start really just by, I suppose, getting people's perspective on this as a problem in terms of its magnitude, perhaps some of its causes, and just get some reflections from each of you on that theme. Do we have any volunteers to start? Palesa, can I start with you?
Good morning, everybody, and thank you, Mpiko, and thank you so much to the SACS, the South African Society of Clinician Scientists, and the UCT chapter of it for putting together this fantastic meeting, and my fellow speakers. I am in awe of the people who are in this meeting. Mpiko, I was hoping you're going to pick on the big people first.
You are a very big person.
Thank you so much. So I am inspired by the talks that were given in the morning, particularly about leadership. And sadly, I think we are so far back. You know, the whole thing about the vacuum in leadership, we have undergone a long period where there was no building towards leadership. And there are many reasons for that. You know, there's been, you know, a lot of gatekeeping, I may say, with what I've seen in terms of, you know, those who had the skill and the knowledge actually wanting to be, you know, the only person. And we tend to forget that this needs to be a cycle. You know, you continuously need to build people because somebody is going to need to take over from you. And you know, this train needs to continue to move. So we therefore don't have a culture of research among clinicians because we have been in a culture where there are special people who are actually clinician scientists. So it becomes very difficult then to break the cycle and make it normal to be a clinician and to be a clinician scientist. And if you look at some of the people that Salome was talking about, the group that, you know, got together and became friends because we had a common theme, a lot of those were basically, I would say, seeds that were breaking through cement, you know. So the question is, as clinician scientists and leaders, how do we make it possible then for this culture to be cultivated widely and become the norm and become fashionable to actually be a clinician and be a scientist at the same time? I think I will leave it here for further discussions and hear what my other colleagues are saying.
Lovely, thank you. Yanalisa, as I said, recent discussion and your perspective really inspired this as a theme. Really look, what is your perspective on the nature of the problem?
Thanks, Prof. So I'll just add on what Prof. Palesa was saying. So I think we need more visibility from the people that have gone through the whole path of becoming a clinician scientist. I think standing as a medical student, I think it would help when people share their work, because many students, especially those who have never heard about research about clinician scientists and how that fits into the bigger picture of our African healthcare. So just hearing about the stories and people sharing what they've been doing and how that adds to our healthcare, I think that would inspire a lot of students. Also, I just, at this point, I remember a quote that I saw on LinkedIn earlier on that said so it's a refined version of it. So it says that a leader finds a way, but you do not stop there as a leader. You go the way, you learn the way, and you end up showing the way. So it means that you create a cycle of knowledge. So you share the knowledge with others. And I think that has not been done a lot. And that's where I think we lurk as fellow clinician scientists and aspiring clinician scientists, because I believe if we get into this knowledge cycle of sharing what we've learned with the future, because so the future medical students who are going to have to take up the positions of being clinician scientists and adding more to the African research that is pretty much non-existent at this point. So I think that's where I'll end.
Right. No, wonderful. Thanks for those insights, those preliminary insights. We'll come back to engage with one or two or three issues that you brought up there. Tivani, can we hear from you about your perspectives in your role?
Thank you, Prof. Vincent, for inviting me to this panelist, and I'm very delighted to contribute to this topic that I'm very passionate about. So I'm going to maybe add to what Yanelisa and Palesa have alluded to, and maybe add my bit to it. So I believe that clinical scientists in South Africa have access to a lot of the financial resources, but there's one resource that is really not is not there. It's actually lacking. Is the resource for enabling the research capacity building. It's not really there. They have the finances. The capacity building is limited, and also the mentorship. And I also noticed in my position as a research dean in University of Pretoria is that we have to look at this from not only from the MEd level, which is the postgraduate level. We have to start capacitating our clinical scientists from undergraduate students. So, we've identified that gap, and that, our undergraduate students actually see research as something that's alien to them. And we've put together a program for undergraduate students to be involved in research and get mentored by some of the advanced researchers, and also be part of research activities and part of research projects. And some of our undergraduate students are even co-authors of publications. So I believe in terms of the resources financially, there's quite a lot directed to this group, but we need to perhaps look at how we, make access to the skills, hands-on skills of conducting research, and also research leadership, and not only start at a postgraduate level, start right at the beginning at undergraduate. Thank you very much.
Okay, excellent. I do want to say before I probe Lionel a bit, that there's a Q&A facility, and so although this is a moderated discussion with the panel, I'm more than welcome questions from other members of the faculty, and of course the audience, most importantly. So Lionel, you've heard from our other three panelists. Looking forward to hear what you have to say here.
Thanks very much, Mpiko, for this invitation, and thank you for the organization for inviting me. I mean, I've been listening quite carefully, and I have to say some of the thoughts that have been raised are quite important thoughts. And so the way I reflected on today was a little bit differently in terms of what do we leave today with in terms of the commitment for leadership. And so I just reflected a little bit about what I'm calling the space between the things that we say and the systems in which we operate. So I want to make perhaps 3 points, and all of them are really reflective of the relationships of leadership that emerge. I want to pick up Dr. Maphai's comment about the tango. He spoke about it takes two to tango. And it evoked again the notions that Roel Khoza speaks about in his book, Attuned Leadership, about leadership as a question of dance, this interaction between the leader and the follower. And so I'm going to just try and speak a little bit about the relationships that ensure the development of this next cohort of people. Because I think Palesa is right, that the perceived exclusions are engaged in different ways, but maybe the important thing now is that as we come to occupy spaces, it is about trying to redefine the relationships that we have. And I was struck this week with on Mandela Day on Monday that Don Matera died. And so I've been thinking a lot about his own journey through life and the different positions he occupies across a lifetime. He starts as a gangster in an area called Westbury, which was part of the Old Sophia Town process. That was where the colored people were moved. And he starts as a leader in a gang, and then he becomes a leading Black consciousness poet, and then chooses to return and stay in the community where he grew up. All of those different dimensions of leadership, and perhaps that's the kind of process we need to be engaging in, is what is our personal role, and then what is our system role in that whole process. I grew up in a Christian activist organization in the 80s, and that's probably the first time I led anything that challenged an establishment. I was talking to somebody the other day about sitting in the dean's office demanding a change for students, and how while we sat in the dean's office, we allowed them to continue with the work that they were doing. But I want to suggest that from that time, a process that we used in the Christian organization I was part of was this idea of seeing, judging, and acting, and creating this iterative, reflective cycle that we need to see the problems that we have. And I think we're past masters as African leaders of listing the problems and giving great speeches about the things that are wrong and need to be changed. But we often don't apply, and I'm guilty of that myself, we don't always reflect on the lenses we use to understand those problems. And then we're not very specific about the actions we take. I mean, some of you, like yourself and people, your actions, I mean, in fact, in one of the quotations from Don Matera, he speaks about his mission. My mission is to help remove pain and suffering from people's lives, to remove the invisible chains, but my work is a shadow of my actions. And that's a key thing, isn't it? Is that we've got to broaden the base of people who are having these creative reflections. And then acting in a particular way. Either sometimes the actions are solo, but sometimes the actions are in a collective. And I think we've got to keep this notion of repeatedly coming back to what do we see is happening, what lenses do we use to understand it, and how does that inform the actions that we take? Because I think for me, leadership is primarily about acting. Thanks, Mpiko.
Excellent. All right. So, Lionel, I'm going to pick up on two things. One is this last reflection you made and bring it tied back to what Palesa introduced earlier on, because in a sense, broadening that base of the discussion, who we're having the discussion with, in my mind, ties in very nicely with the idea of culture change, which Palesa brought up as imperative to the solution, imperative to the solution. So Palesa, just to bring you back, since it is with you that we started, let's take the scenario back to your department, okay? How does, as a leader, one implement culture change within a department that historically has shunned research, doesn't understand the importance of clinical research, and doesn't do much clinical research? I'm starting with you, but obviously it's open to the other panelists as well, because I think that interface is one that is a very practical, real challenge for many of us.
Thank you, Mpike. It's quite an interesting question that you ask me. So this is basically then my lived experience. So I took over a department where there was a section of research, and that section of research didn't mean the whole department. You would be handpicked to be part of that section of research, and it wasn't everybody, obviously. But so looking at it in my mind, I felt, in a department as big as this, which has just over 220 people in it, imagine if even half of those people were doing research. Imagine if that half of the people, even half of those, were to publish their research. And it's something that I think Prof. Corrah spoke about, in that, leadership is not the position that you have. It's a position of influence. And a position of influence is difficult. And I think we also should not think that leadership is something you're born with. And it's something that I don't talk about a lot, even with the people that I interact with. That I sit and read books about research, about leadership, because I try and figure out how is it that I'm going to move this mass of people to where I think we should go, number one. Number two, I have to have an agenda. So one of the first things I did when I took over the department is I had a meeting with everyone. I called everyone into a meeting. I wasn't the most popular candidate to take over that position, but I laid out what it is that my plan was. I laid out to everyone my agenda. I sold the story to everyone, and I said to them, here's who I am, and here's where I would like us to go. We are here. I would like us to go here. I need you to assist me. And once you've said that, so you've set the agenda. So what then do? You've set an agenda to people who've never had to do this and are seeing it as foreign. Then you've got to hold people's hands. So then you do individual talk with everyone to the path that you've walked, as Yanelisa was saying. I often see myself as one of these big craters that create a path where there is no path. But now the path is there, right? So you go back to people and you say, look, there was no path here, but here's a path now. It may not look wonderful, but I have walked it and I've gotten that far. Can I hold your hand to move from where you are to get to where I am? And then in that process, you try and convince people, and you don't want to show people this huge mountain that they need to go over. You want to show people the smaller things that they can conquer, step by step. I always say to people, it looks like an elephant, but we need to eat it in bite sizes. So you give people little steps of getting into this culture. Very soon you have a foundation that's higher than where it was. Then you start challenging people again to build onto that, to say, right, we're here now, but I can tell you we can get up to here. And one of the important things as well is also allowing people who are better than you, who have more knowledge, who have more information, to be part of your driving team. Because I've seen leadership where the leader becomes the top person and the person who knows everything. And that way you're not giving yourself capacity to learn as well. So I then realized that you need to bring people into your leadership that have different things to offer and can offer different people different things to be able to move people forward. So that was my starting point, and I continue to build on that as we speak now.
Wonderful, thank you, thanks for that. Tivani, if I can come to you, I'm just going to ask a slightly different question here. Prof. Corrah put to us that in a sense, the ability to communicate to our constituents important ideas. I think he mentioned clarity of thought and ability to communicate our ideas effectively high up on his list of leadership attributes. How well have we as research leaders, research leadership, communicated the idea of the indispensability of clinical research to what we do, which is provide a health service to improving health outcomes? And just to say, my personal sense is that that's one of the things we've been very poor at, is letting our fellow clinicians who aren't involved with research just understand how important an integral aspect clinical research is to what we all do. Can you speak to that, and in particular how we might be better able to communicate that?
Thank you very much. for that question. So I think I will look at it from, from a perspective of the importance of, the health ecosystem, the ensuring that we conduct research that contributes to the health evidence ecosystem. So if you look at that health evidence ecosystem, it really pushes us to disseminate the research, or before even dissemination, it forces us to actually co-create our research questions in collaboration with the stakeholders. So if you look at that entire ecosystem, if we are collaborating with the stakeholders, meaning the users of our evidence, in structuring our research questions, it would not be difficult to communicate the findings with them. And if we also ensure that at the end of conducting our research, that we timelessly disseminate those research findings to the right, the relevant stakeholders in the appropriate format. Meaning that when we're disseminating to the scientific community, obviously we need to disseminate through the journals. When we're disseminating to our policymakers, and which are very different, we have different groups of them, we use the right formats for disseminating and communicating our research findings to all the stakeholders. So coming back to the policymakers or to the governments that you're talking about, we obviously have to structure the communications to suit their platforms. So in the University of Pretoria, we are very lucky to have, a department that's led by Prof. Flavia Kumbuke, who is very good at assisting our office, the research office, in communicating, the key research findings that needs to guide policy, health policy. She helps us, with communicating those findings to the government, and hopefully, we will see more and more of our evidence influencing practice in South Africa and beyond. Thank you very much.
Thanks for those thoughts. Lionel, before I go back to Annalisa, so the role of sort of back to basics, the role of curriculum. We talked about communication, culture change, et cetera, et cetera. And we talked about sort of trying to stimulate the idea of becoming clinical researchers and introducing these links very, very, very early on. Is clinical research and part of the solution to the longer term not better placed or stand a better chance if we start embedding it in our curriculum? My sense is that, again, I don't know that we have that embedded in a curriculum where the culture is embedded in the curriculum, and students can grow up and graduate through medical school understanding the importance of clinical research. Your thoughts?
I think that's a really important question, because I'll share two experiences. I ran a curriculum at Wits in which the undergraduate research activity was deeply embedded in the process. So it was a requirement in the 5th year of study. I can't tell you what it looks like now, but I think we must balance the nature of the input we have in the curriculum. So for me, one of the challenges, and I'm going to talk about medical curriculum particularly, because I think it's less so a problem in the health and rehab sciences, which we often exclude from this clinical scientist conversation. And I want to just highlight that in the background. But it is about the fact that many of our curricula remain committed to content rather than process. And so how we conceptualize the insertion of research and its engagement in the curriculum must be adaptive to the situation and the stage of the student's development. Is it conceivable, for instance, we partly commit to a problem-based learning curriculum. We did at Wits and we do here. but in fact, we don't always trust our students to ask the right questions of us. And I see there's a question from Cassandra Reddy asking about the limited interactions between departments and undergraduate students. So while I think it's absolutely crucial for our students to leave the system with a very clear understanding of the role of clinical research. I mean, just to give you an example, in the UCT system, we have people here in the biomedical area who teach innovative drug delivery systems. They never speak to our medical students. And so we almost, that's the challenge that we have. So I'm not always sure what people say when they say there should be a greater presence of research in the undergraduate curriculum. At UCT, the system is to get the students at least to write to proposal writing level. At Wits, we wanted them to write the proposal, take it through that painful process of ethics, do the practical research, and deliver a project within 10 months. I mean, the number of students I had to, who leaned on me in that period was quite phenomenal. And so, and that's why I talk about this iterative reflective cycle. What is the thing we're seeing? Because the gap between graduation and actually entering specialist training, which is usually the domain from which clinical scientists will emerge, is quite big as well. What happens as an intern and as a ComServ that maybe erodes any kind of ambition you might have had for the future? I mean, we at the Committee of Medical Deans level, we're trying to talk about how do we change the community service here? Is it conceivable that in the community service here, we will create paid posts for that student who has an interest to work in a research unit and allow that to be translated as equivalent to community service in a context where the government can't afford it? And I think we've got to stop pointing fingers at government for the way we think in this area. Thanks, Mfiko.
Okay, wonderful. Yanalisa, there's been a request from the audience for you to address your experience of the degree to which you've experienced a research culture within sort of the question that I asked Palesa early on. What is your experience of the research culture as a medical student? And perhaps you can share with us why it is you chose to go the intercalated program route and what inspired you to go that direction.
Okay, thanks, Prof. So my journey is different from many because I come from a very small village in Eastern Cape. I never knew what research was and what it holds. And I only found out in 2019, and the way I found out was through a friend. So they were in the intercalated program and they just posted their thesis, their submission of their thesis. And when I saw their submission, that's when I knew this is what I wanted to do before even getting to medicine, because my idea of what medicine was is completely different from what I have experienced when I came here. So my idea was, so when you come to medicine, you come to a place where you find solutions, and you find solutions to the healthcare issues that we have. So meaning conducting drug trials, even though then I didn't know what a trial was, but that was my idea of developing drugs, trying to figure out what's happening with our genes and carrying out answers to most of our healthcare issues. And so that was my journey. And that's why when I saw that thesis and I got to know about the intercalated program, and I got to try to fix myself in getting towards getting accepted for the program. So I was lucky in that sense, because some medical students don't even know now. I mean, some students are in their 6th year, they don't even know the intercalated program. They don't even know it exists. They don't know much of what the faculty offers to students in trying to close the gap of clinical research for medical students. So pretty much that was me. That's my journey. But I think more could be done. A lot needs to be done, because I think the foundation for clinical research for medical students specifically is pretty much non-existent. And I think if we try by all means to tackle it right at the foundation, so which means that if we try to tackle it at undergraduate level, so first year level, if we introduce students to research as they come in, I think we can have a better outcome of more clinical scientists and clinical researchers if they know at a really early level what research is and what it has to offer, and the opportunities that we have as we try to also create more opportunities for students in the faculty.
Excellent, excellent. Tivani, if I can come back to you, there's something you said earlier that I found intriguing. And you talked about, if I understood you right, that from your perspective, funding hasn't been the major stumbling block. You know, it's the many other aspects that actually are where the challenges lie. Can you expand on that? It's very few people who have that perspective, and it's certainly not my personal experience. Can you expand on that?
Yes. Thank you. Thanks for also emphasizing that it's from my context. So my context obviously is from my, research leadership at the University of KwaZulu-Natal and in the position of research leadership in University of Pretoria right now. So in both of these two institutions, research funding is very accessible, and this group of researchers and clinical researchers have access to the research funding that is, that is offered to all research students within the institution. There's that one funding, and also there's now you have the MRC and Discovery and others that are clearly focused to clinical research and clinicians. So that's additional to what is accessible to everyone. And I know the two institutions, they fund research very well. So the funding has never been a problem. So in my position, I've had colleagues or peers that were clinicians and I was collaborating with in research studies, and also in supporting in my support position as a research leader. And I've noticed that we don't have well-structured mentorship and research capacity building initiatives for that. That is, I would say it's focused at that particular group. We have a research capacity building initiatives that are like suitable for everyone, but we forget to, we're not focusing on the challenges of clinician scientists or clinical staff that are conducting research. So in my context, let me talk about the MEDs, the registrars that are struggling with completing the research component of their training. We don't have well-structured, I'm generalizing. We are looking at that to look at modeling something that is suitable for that group, to enable them to incorporate research in the work that they're doing and also complete the research component with ease. Because for me as a medical scientist who was trained on research from like the first year of my training, I find that if I had access to patients, I'll do research very easily. I have access to data. What's the problem? So you see, now that I'm in a position to speak to clinician scientists or to registrars, I can see where the challenge is. There is no mentorship, and maybe they've not been exposed to that research skills and knowledge from undergraduate level to be in the same position as me, where whenever I'm close to a patient or close to data, it's like, what's the issue? Just use your knowledge and then do research. I would even look at it as I could complete the research component of the MEd in my first year because you have access to data. But where is the mentorship and where are the research capacity building initiatives to enable them to have knowledge of research methods And that's where I saw this was lacking. And I'm just hoping that we can structure something specifically for that group. Money, I don't think is a problem.
Thank you.
Thank
that,
you.
Clarifies that point quite a bit. Thank you. Palesa, I see your hand is up.
Thank you, Pico. I think we need to be very cognizant of the group of people we're talking about, the clinicians, because, and there was a question in the chat about it. How do we, how can clinicians manage to do clinical work? And this speaks to what Prof. Tivani was saying about having patients and you can do research. Unfortunately, for clinicians, having those patients means work. You know, those patients are there to be treated. So there's that major problem of clinicians being in the clinical space because they are there to do work. And it gets so overwhelming sometimes that, you know, all the clinicians can think of is that this is a duty. So as a clinical research leader, what I think is very important is to teach the clinician the interface between work and research, and showing them, you know, the easy path of transitioning into a researcher where you are. You know, that the material you have, this material that seems like a lot of work, is actually research material. And this is a story you can tell about your own work. You don't need somebody to come from outside to come and collect data in a unit where you're working to tell the story about outcomes, to tell the story about efficiency of medicine or anything, and go and publish it. And perhaps, you know, thank you if you were somehow useful in, or you were helpful in that. But it's a story you can tell, and it's part of that leadership where you teach people to hone into this. You know, we did a study at Bara, which was this was work that was being done by clinicians. They were filling in a form to see how they were giving morphine spinal to orthopedic patients. But it's a question, is this safe? Because we don't have resources and we would like to put these patients in the ward after this type of treatment where we think they get the most benefit. How much of the side effects are they getting? Is it harmful to them to do this? The data was there, the clinicians were collecting data, but they could not make a connection between their research aspirations and the work that they're already doing. And that paper is published. And it's so interesting because about a few days after that paper was published, where we're basically saying it's safe in an environment like ours. It is safe to treat patients this way, put them in this place where there's no monitoring, because we've looked at this data and no one had any complications that were life-threatening. So it's that type of you know, teaching people that the data is right there with you. And there's data in Africa that is not the same as data anywhere in the world. It's our special information that we should be telling. This is what we should be telling, that nobody else is telling. Thank you.
Thanks, Palesa. Very important insights. Lionel, I see your hand is up.
Yeah, thanks, Mpika. Maybe as a concluding remark, really, because I mean, it is about the extent to which we're able to embed a research competency in what specialist trainees see as their toolbox of capacities and competencies that they develop over time. There's a current pressure in the system which devalues research to a large extent in regarding it as an added extra. And it's a dialogue we have to engage with. Although I have to say, I'm quite impressed, Professor Mashamba-Thompson, that you reckon that the money is not a problem. I want to tap into your box a little bit. But Mpiko, I may have to step out in the next minute or two. I have something at 11.
Okay. No, thanks, Lionel. Can I just check from, I think it was Larato who was going to tell us time-wise Unfortunately, my timekeeper here has failed me. We're just about where we are.
You've got about 2 to 3 minutes.
2 to 3 minutes. Okay. In that case, I think what we'll do is Lionel's already sort of given us his concluding remarks. What I will do is seek sort of concluding remarks from everybody. One thing we didn't touch on here, and perhaps you can touch on it when you conclude, is actually, you know, we've talked really about the importance of research leadership and us as research leaders to try and bridge this gap that I tried to contextualize at the beginning. So the question will be about trajectories for clinicians to become research leaders per se. Okay, and whether that needs to be formalized. We heard Professor Corrah's very strong belief that, in a sense, you have to be an excellent clinical researcher before you become a leader. I suspect others in the group might differ and say that there's space for some balance. Sometimes, particularly in an environment like ours, we have to lean a little bit more on the leadership side of things to drive the research. So as we conclude, and I go around the panel, perhaps I'll ask you to comment on that aspect. Palesa, can we start with you to do the concluding remarks?
Thank you, Mpiko. So I think Lionel is back. Can Lionel start the concluding remarks before he goes?
Okay, Lionel, if you can just comment on what I just said, if you heard me. Lionel, are you still with us?
I am. No, I really I think that tension between leadership and leadership of research and leadership of the space is really important that we discuss it, because I do worry that, I mean, I had a conversation with some of the leaders in the room here about, do you want to establish yourself as a leader in a space, or do you want to establish yourself as a political leader in the academic space? And I don't think we've refined that conversation sufficiently. And I think it's one we need to be intentional about in that reflective framework I was talking about earlier. Thanks, Mpiko.
Thanks, and thank you very much for your contributions, Lionel. Really appreciate it. Palesa?
Thank you, Mpiko. I think to just pick on from what Lionel was saying is that I believe that both ways it's leadership, and I think Salome will perhaps attest on this, because we've sort of like walked some of the path together. There will be research leaders who are towards the line of policymaking, and there are research leaders who are on the line of producing. As I say to the people I work with, I see myself as the trunk with very shallow roots. And I'm hoping that with the little trunk that I am and the shallow roots, I can, they will grow from my experiences as the branches. And the bigger the branches grow, they will feed into my trunk to be bigger, and my roots to go deeper. So I'm hoping that they will also have branches of themselves as they become bigger branches. And that's a path you choose. You can choose to be that leader in the research space, basic, or you can be a leader in global health policy making. But whatever you do the best and be the best at it, or try your best at what you're doing. So you can choose that. And I for myself have chosen to build, onto new researchers. And the best thing that I have seen in the group of people I interact with is when you see your branches branching off on their own. You see the people you've held hands with to move them into the research space. You see them publishing without you, with their own little group. That's the best feeling. And I always complain that they left me behind. But it's the best compliment ever, because you're looking at people who are growing right in front of you, who have now become an independent branch that is branching off. So that's the best thing you can, that's the best compliment, to be left behind by people that you're building on. And also, very importantly, leadership in this space is not being the best at everything. It is being able to lead a group of people and using their expertise, to benefit the whole group. Thank you.
Thank you. Thank you. That's lots of food for thought there. Thank you. Yanalisa, some concluding remarks?
So I would just closing, I think it is a task for everyone to invest on student leadership, student research leadership to be specific, and the general knowledge cycle that I alluded to earlier on, a knowledge cycle that basically feeds to our common goal, which is to better our healthcare in Africa as a whole, knowing very well that now things have become more European than ever, and I think we need more African leaders to take up the space and to change the trajectory of our healthcare.
Okay, wonderful. You've thrown down the gauntlet to the existing leaders and future leaders. We now know what we need to be thinking about. And again, I want to thank you very much for your very important contributions this afternoon. So we'll save, I suppose, the best to last. Tivani, concluding remarks, and again, just honing in on this last aspect of trajectories and this tension between research and leadership.
Thank you very much. I'll be quick. So I would really want to look at research at leadership in a context of research leadership, and using Prof. Corrah's definition of research leadership, and he's made it clear what we mean by research leadership. So if we are really serious about having clinicians lead in this research space, we really need to think about enabling them, enabling the research leadership development right from undergraduate level. I think it's a little bit too late to want to catch someone right, when they are finishing off their training, and then you think they become appropriate leader and really lead in the research space, while there are other groups within the health environment that have been trained to lead research from undergraduate. If we want them to be part of research leadership, let's focus on including these components of research leadership as part of, as we are transforming the medical curriculum. If that can be incorporated, then we will truly find future research leaders from the clinical space. Yeah. Thank you very much.
Excellent. With those words, I hope you've enjoyed the session as much as I have. Lots of food for thought there. I must admit, I've learned a lot. It's stimulated a lot of thinking, and I know there are many decision makers in the audience who I hope have also been tuning in and have been stimulated to think about potential things that they can take back to their environments. And with that, I'm going to hand back over to the program director and say thanks to everybody for tuning in and listening. Thanks, and of course to the panelists for an excellent session. Great.
Thank you so much. Thank you so much to yourself, Prof, as well as to the panelists. I think the discussion was incredible, and we appreciate both experience and insight in moving forward. We're trying to now claw back some time, so we're going to ask for a comfort break of about 5 minutes. We still have to go into our second portion of our panel discussions. So if you could just either go for a nice comfort break, grab yourself a cup of coffee and return. We will start promptly at 5 minutes past 11, at which point Dr. Lerato Katle will take over and facilitate the next session. Thank you very much. See you in just a few.
Recovery Health.
and an adjunct professor in the School of Statistics and Actuarial Science at the University of Witwatersrand. She's got over 27 years in South African healthcare and employee benefits field. Her current role involves industry engagement at high level, including regulators, government, civil associations, industry bodies, and supranationals. And she's participated in NEDLEG engagements and national health insurance, as well as presenting evidence and analysis on the health market inquiry. Welcome, Professor Roseanne. And next we have Professor Musa Mushabela. He is the professor at UK's Professor of Public Health in UKZN. He is also the Deputy Vice Chancellor for Research and Innovation. He is a Wellcome Trust Fellow, and he was awarded the Ministerial Special COVID-19 Award for 2020-21 for COVID-19 Science Communication and Public Health Engagement. He's got an illustrious CV, so these are all short. I'm trying my best to actually shorten most of these bios. And so importantly, he's actually in he's actually a chairperson of the Standing Committee for the Health in the Academy of Science of South Africa, so ASAF. And he's the chairperson of the committee to evaluate COVID-19 health sector response in South Africa, which was commissioned by the National Department of Planning, Monitoring and Evaluation. He's also the Health Commissioner for the Premier of KwaZulu-Natal. And so basically, a lot of these panelists have a lot of experience with translating policy. So lastly, I want to introduce Professor Liesl Zulke. She's the Vice President of the South African Medical Research Council, the Extramural Research and Internal Portfolio. She's a pediatric cardiologist in the Division of Pediatric Cardiology in Red Cross Hospital, and the director of the Children's Heart Disease Research Unit, which is focused on family-centered research into children's heart diseases. Professor Zulke's research spans congenital and rheumatic heart disease, HIV in adolescents, congenital heart disease, and cardiac disease in women of childbearing age. She was the MRC DFID African Research Leader Award winner and finalist for the 22nd National Science Technology Forum South 32 Awards for the category of TW Kambule NST Award. So they have illustrious careers, and I apologize, I had to shrink it into the first 5 minutes just to speak about 4 of them. But I just want them to tell us, how did their career journeys prepare them to working into translating into policy? We'll start with Dr. Klute.
Thank you very much, Pumla, and really thank you to everybody for inviting me to be part of this. I'm really excited about sharing the stage with Liesl, Mosa, and with Roseanne and yourself. And I really commend you for the manner in which you introduced the CVs, especially of my colleagues. I found that very interesting. So really just to the question of how my background prepared me for this place and where I find myself in a place in terms of the translation of research into policy. So it's a very simple background. I think of myself as a primary care clinician that worked in the system. And while I was working in the system, and primary care clinicians are pretty busy in terms of seeing a lot of patients. So I was very pleased by Palesa's recommendation, is that in doing my job as a primary care clinician, I was curious to understand, why is it that we have so many people keep on coming back, and why are people ill, and why are things getting worse, not better? So that's a curiosity that I regard. And I believe every clinician or every person working in a system should be curious enough to ask questions. If you ask questions, it takes you to a research frame, and it takes you to the frame of understanding data and understanding evidence. And if evidence and data is key, it influences the way you make decisions and how you move. So I think that background, and I spend it in basically the breadth and width of the public health system in the Western Cape, to the point where I became the HOD. And as I became the HOD, probably we had the most significant, and Mosa can talk about that, we had the most significant challenge of saying, how do you actually do in real time translation of evidence and research into policy, into implementation, into impact? And that was the advent of COVID. And I think we've done exceptionally well as a South African society to actually lead the way in many instances, I believe, of how that is possible and what is required. But my big thing is that the big thing that prepared me for this is the big experience that I've had and the privilege I've had to actually be mentored, to be coached, to be nurtured by people that went before me with a very, very important ingredient, and that is how to be a good leader. So that I embrace, and that is my story and my journey to this very exciting point in our country's history. Thank you.
Thank you so much, Dr. Klute. I think we've heard even from the previous session that mentorship is one of the important things that can happen. What about you, Roseanne?
Yeah, thank you, and good morning. Thanks so much for inviting me to be part of this event. What an inspiring session you've put together. So I'm an actuary here amongst this very illustrious group of clinicians, so feeling a little bit intimidated. But let me tell you a little bit about my journey then. As you said in your intro, I do wear a number of hats. I have this health policy role at Discovery, which is very stimulating. I'm an adjunct professor in the School of Stats Natural Science, where I teach honors students and work with them in research and supervising PhD research. And I'm also currently president of the International Actuarial Association, which is a great honor and quite time-consuming for me this year. But my career as a health actuary in South Africa has involved working in multidisciplinary teams with clinicians throughout my career, and this has been really a rewarding aspect of my work. It's involved developing, I guess, what I would call mutual respect, as well as reliance on each other in terms of tackling various problems, both in academic and commercial, and of course the health policy spaces as well. So from a research perspective, I've published on topics ranging from modeling the impact of HIV and trends in NCDs, and also addressing inequality in health systems and managed care and anti-selection in health funds. So around sustainability, I would say, is probably the key topic there. And none of that would have been possible without the input of clinicians and other experts as well. So when I embarked on my professional career as an actuary, I didn't certainly expect to find myself in an academic role, but healthcare was not a mainstream area of actuarial practice. And so I engaged with the opportunity to bring actuarial techniques to sustainable funding for healthcare. And it was timely because when I embarked on my professional career, it was a time when healthcare inflation was becoming really rampant. So I guess it was that curiosity that Dr. Klute mentioned, as well as the desire to contribute to applying actuarial techniques to health problems, as well as that stimulation of working in a multidisciplinary team that led to me blending basically a 20-year career as an independent consulting actuary with an academic career as well. And then when I was given the opportunity to join Discovery, it did seem like a natural progression to follow that passion. I was able to continue with my academic role with Discovery support, thankfully, as well as to make a contribution to the profession. But more importantly, it gave me, I guess, a platform for providing input to our country's development in terms of this pathway to universal health coverage, which is so important in terms of addressing inequality in access. So finally, in my role with the IAA, the International Actuarial Association, it's a platform that I've aimed to use to promote the concept of our profession working collaboratively with other professions, so like clinicians, but also economists and environmental scientists and other scientists, to contribute to finding the solutions to the kind of macro societal problems and challenges that our world is facing. So I guess this kind of multidisciplinary theme and the stimulation of working in that environment is really what has led me to the roles that I fill today.
Excellent. It sounds it sounds like you following your passion in actually improving the healthcare in South Africa. What about you, Musa?
Yeah, thanks, Prof. I think that for me, you know, I echo the sentiments of my colleagues who just spoke, and it has to do with this sort of broad interest in medicine. And of course, as a family physician and a generalist, my interest was very much about how to connect the dots. My frustration, and I think that Professor Maphai alluded to it at the time when I was practicing as a clinician, was the fact that, you know, I had all these evidence-based guidelines on how to manage conditions, clinical conditions from a clinical perspective. And my frustrations did not quite come from there. They came from things that I didn't have answers for, which have to do with broader issues, systems, and so forth. And I sort of embarked on that journey of trying to find answers and finding solutions. And I saw how it sort of affected people. So you'd be sitting in a clinic, in an HIV clinic, and then you will see a patient, but you don't know whether that patient is going to come back or not. You also wonder why the patient is coming to the clinic with a very low CD4 count when they could have come in earlier. So those kind of frustrations are the ones that sort of propelled me to start asking questions about broader things. And when you start asking questions about access, quality of care, you go into systems, inevitably you go into policy, and then you start to learn about that whole landscape. At the time, of course, I wasn't really trained or taught about that space. I had to sort of learn on the go. And once we sort of get into that space, especially around the time of HIV, there was this sort of explosion of new knowledge, and we constantly had to learn how to read the evidence, synthesize the evidence, turn it into key messages very quickly in order to make decisions that were very much pressing at the time. So I would say that that whole experience is the one that propelled me into this space. And once I was in the space, then I had to learn how to navigate it. And the biggest thing that I found there was really to form relationships of trust with people who are implementers, who are decision makers, who are policy makers, and also find credible structures that then allow us to be able to provide the necessary evidence, which is oftentimes requires to be synthesized from different sources and peer reviewed and then essentially written in a way that people can understand and communicated in a way that people can understand. So I would say that whole journey, especially the HIV era, really kind of pushed me into that space. Otherwise, today I probably would have been a trauma surgeon, but here we are.
We are lucky that you didn't become a trauma surgeon. Lizzo, tell us about your journey.
Yeah, good afternoon. It's still morning. Good morning, everybody, and also to all of the people watching online. Really just again to add my thanks to the organizing committee for inviting me to be part of this wonderful panel. I've thoroughly enjoyed the answers already, and I'm wondering how we can really utilize them. What else can I possibly say to add on to some of these very common themes, actually across 3 very different careers. I started my career in pediatrics. I always teased and said I went to do medicine so that I could become a pediatrician. And obviously thinking just about how to heal the particular child in front of you, but very quickly realized that we were facing the social determinants of health, the issues in the family, the issues in the environment. and that many of the questions and the solutions were actually around much broader issues, like Musa also alluded to, and how that started sparking off different ideas and goals and visions in my own career. I moved into pediatric cardiology, again, because of a desire to want to be around for the whole of the life course. One of the things in pediatrics, if you work in a tertiary institution, you may see somebody with an acute illness and never see them again. What was very nice in pediatrics is sometimes making the diagnosis of a patient in utero. And now at this phase of my career, I'm looking after the women that I looked after as babies. And there's a very special environment to that, but of course also speaks to the research of the life course. And how, I know Keith is, this is something at Keith's heart, how what happened in utero affects them now in their older age. And again, a whole series of research questions there. That's fantastic. What I notice, and again, this is part of that commonality between all of us, is those pragmatic and sobering pieces of evidence. In pediatric cardiology, there's been massive improvements over the last 50 years. Survival rates about 97% now for even critical congenital heart lesions. But that's in high income countries. In low and middle income countries, we're probably 60 years behind with some of those variables. My particular research was in rheumatic heart disease. And there again, we've got 80 to 90% of the world's cases, entirely preventable condition, lowest amount of research and development funding. So, you know, it was those sort of hard realities that made me want to do research and get involved in some of the policy as well as the practice, evidence guidelines and impact. But again, echoing now Roseanne, one of the important things there was working with different agencies. So in a lot of my RHD work, I'm sometimes the only clinician in amongst groups of health economists, advocates, global agencies, which I found to be very, very interesting indeed. I'm almost always, hopefully not always from the future, but often I'm the only woman on the panel in a group of cardiologists, often the only African in the panel of a group of cardiologists. And that's also something that's really not only now an advocacy piece, but a research piece. You know, why is that the case? What can we do about it? How can we change that? How do we actually develop systems to change that and monitor that so that it's appropriate? But I wanted to add one other thing. Just in terms of my career, in last year, I was the Deputy Dean of Research for a period, and that was a really important avenue to be a researcher, but also to empower other researchers to develop and to grow and to really reach their full capacity. And sometimes we think we must just be doing our own work. It's actually very important to grow and develop and help other people. My personal mentor was Professor Bongani Mayosi, and he used to tell us one of the things is always read outside your area. Be curious, be interested in other areas. And so one of the things I was very interested in during the COVID period was the wastewater project that was being run by the SAMRC. And I used to follow their dashboard to see which new variant was coming, there was a new lockdown on the horizon. And that's actually how I saw my current job advertisement. And so I do want to remind people, sometimes there's a bit of luck and a bit of serendipity in your career. And that has now given me the opportunity to help conduct, fund and empower research capacity building. But in particular, one of our strategic goals is to actually focus on research translation. So that I think is it in a nutshell, but a final point is that my PhD was actually conducted partially in Ethiopia, but also in the Vanguard community. I see Keith is nodding his head. I come from that community. So it was a particular thing also, again, when we think about policies, to root it back in the community, in our community stakeholders. And it made it very nice that after a day of screening, I would go home for a cup of tea with my mum and go and buy a cook sister from the auntie around the corner. So that's it. Over back to you, Pumla.
Thank you. Thank you for bringing us back to research and translating the research into policy. But most of us as researchers, we all hope that our work is going to end up in the Lancet on the NEJM and then translated to policy. But what do you guys think are the major challenges of translating research into policy? Because most of the time the research disappears in the journals and never actually translates. So we'll start with you, Lizo.
Yeah, thank you, Pumla. Very important question. And obviously the journals are important. That's how our research community hears about it, but it's much more than that. And in fact, sometimes, it almost is okay if it's in a very small journal, because it's what you do with it afterwards that matters. And in fact, even policy is not where it stops. So one of the outputs from my PhD, which is in rheumatic heart disease, has led almost directly to a WHO resolution against rheumatic fever and rheumatic heart disease, which is wonderful. But we are very involved in now trying to take that again from a policy, a written document, to actually implementation and changing and impacting lives. And that sometimes needs to be done by getting different stakeholders involved, trying to actually be that intersection facilitator with, departments of health, departments of education, of finance, of justice, because that's sometimes where the real power play happens to be able to implement it on the ground. An example from the MRC is the work that they've done on lead and understanding lead poisoning. That's happened over many years. But to change actually what we're going to put into our cars is a whole different area. And so I think this is there are just a huge amounts of obstacles in this area, but this is where we need to think out of the box. We need to contact our colleagues in other disciplines and other areas. We need to learn from those, how we can bring those to the right people, and then follow through and often take a back seat in that, which I think is absolutely fine, and let people who can change the policy and make it into practice do their jobs.
Okay. Roseanne, what have you found as the major obstacles that people face when they're trying to translate into policy?
Yeah, I would agree with the point about advocacy, but actually, I think in South Africa, we are really good at writing evidence-based policy. We have really good policy frameworks, in fact, when it comes to some of the core challenges, particularly around inequality and access to healthcare in South Africa, for example. I would say our challenge comes in translating that policy into action, to echo what Liesl is saying, and almost like this fear that holds us back, that everything needs to be laid out perfectly before we even take the first step. So there's certainly the need for research to substantiate policy direction. But I think we also need to have a bit of a framework for learning on the go as well, so that we can build that bridge between solid, sound research that leads to evidence-based policy development, but then leads to action and evolutionary action from the perspective that learnings along the way are then incorporated and you have continuous improvement.
Great. Mosha, what has been the challenge in translating your research into policy? Or you can also put in general what you think the major challenges are.
Yeah, I mean, there are many things one could say here, but maybe I can summarize it as follows, to say that I think from the time I was still an early career researcher, I found that I did not quite have a voice. It was very difficult, even if I remember in 2006, and I was sitting in a meeting that was organized by the Nelson Mandela Foundation around HIV. And, I made a point that I thought was a really good point, but in a way it just fizzled in the room. until someone else who is much more senior and well-respected repeated the same point. And that point was now taken very seriously. And I was like, what just happened? And for me, that's where I actually learned that one, to influence policy, there is a need for credibility. The one is to build credibility in terms of gravitas as a scientist. People need to see your track record, need to trust you in terms of what you bring, credibility in terms of the research that you do, you conduct. And that's also why how somehow the papers that are, the evidence that's published in high impact journals is also trusted because of the rigorous processes through which it's reviewed. And also to produce that level of research, you need to invest in very high quality methods of conducting the research. Those require good teams, they require good funding and all of that. So there is a whole notion of credibility that I think it's really important. The second one I want to mention is time. Time is so difficult to secure in terms of getting to communicate your results, getting to have other people hear your results and your evidence. And we find that even in our system, especially as an academic, there's very little rewards for engaging or in sort of policy processes or spending a lot of time in the policy space. There's more rewards for the actual output that you produce, but not so much for turning your work that, into policy and societal impact and so forth. So time becomes important. The last thing I just want to say is that I think it's also a problem of that has already been stated, that we may not necessarily ask the questions that are burning to the people, to the decision makers and the policy makers. And the sort of process of really finding those questions and asking those questions starts with sort of walking the journey with policymakers and decision makers from the beginning. And really understanding what is it that they may need. And it may not necessarily be your immediate priority at the time, but if you're involved in the process of helping them answer those questions, those are taken up quite quickly as well. So I will stop there, but I think that the point that was made about implementation gap really is quite important for us in South Africa. We must, yes, talk about translation of research into policy, but we must not forget about the important question of implementation gaps. Thank you.
Right. I think you're quite right that, we actually do need to bridge the gap between what the academic researchers are doing and what the policymakers want. So maybe, Keith, you can answer how we can bridge the gap between what is regarded as national priorities and academic research.
Thank you very much, Pumla. I'm really fascinated by all three responses. So it's really, I find alignment in the thinking and the approach. So I found something very interesting. I think Musa said it, in our own journeys of discovery, because we mustn't underestimate each one of us here, the four of us had a different journey of discovery, but there's commonalities between our journeys of discovery. A forum like this and a platform which we should create, the ones that Liesel is talking about, Musa is talking about, Rizan, is that we should collectively reflect on it. Very much we tend sometimes, and this is the purpose of today, this is clinician researchers having the conversation. But we could potentially, Musa, have another place where, let's call it administrator policymakers are having a conversation. You could talk about funders having a conversation. You can talk about people that are the economists having a conversation. The question is the thread between those. What I like about this conversation is the thread between the four of our journeys and collective discovery. So I want to just put out something. I read something very interesting in my own journey of discovery. And it is, Musa, you would understand this, because I've always found it fascinating when Musa described this. When you go into that whole, let's call it, Musa, the unknown, the kind of higher level of understanding policy and how factors come together. And it's a kind of a rarefied atmosphere where all these things in the bigger system come together. But one of the things I found very useful is finding the right language to explain, because the common language build bridges. So there's a very nice piece that I read about evidence translation. And so Liesel, this was from Taryn Young, and we had this integration with Taryn in terms of the evidence translation unit. But it was very useful when we did that reflection, where there are 3 points of entry for evidence translation into practice and impact. It's one that's initiated by the researcher, and that's what Musa was describing. Sometimes that is very difficult because your chances of hitting it into translation is influenced by a little bit of luck, as Liesel said, a little bit of receptiveness and your own kind of credibility, and whether that actually leads there. The other stream of translation is from the policymaker perspective. And that is a little bit more, Musa, that is by almost like the heat of the policymaker arena, the language of the life of the policymaker, which is very real, very immediate, and there's a whole lot of things to be answered. So one of those things is, my classic thing I always say, a policymaker doesn't need an answer in 5 years' time. A policymaker needs an answer next month. So the issue is the reality of that. But the perfect, or the, let's call it the more ideal one, the one that I subscribe to and I hear that comes from my colleagues, is the one where the journey is together. It's the collaborative path. It's where the researcher, the policymaker are part of one journey of understanding what are the key questions, what is the key elements to bring together, and then navigating, like a dance, the actual place where this all lands together in a sequence. Many people are just not in the know. I would say the 4 of us, pretty much, if we had to see a policy based on our experience now, and the critical thing for me is all 4 of us have been guided by mentorship and coaching. If it is, it's our leadership orientation that allows us to be able to know which relationship to navigate, which conversation to have where, with who, how, what WhatsApp note, which phone call, which cup of coffee is actually going to unlock these things for things to land. Now, for young researchers, that is what we almost like, it's incumbent on us to say, Musa, that we should not subject a 30-year-old with a brilliant idea now to say that that idea is dismissed. We can change the directory because we now in the places of understanding where that was in the previous generation, we can change it for the next generation. Thank you.
Wow, that was an incredible answers from the 4 of you. I actually wanted to know, you were saying that you need, with policy making, you need an answer in the next month. What did we actually learn from COVID, where decisions needed to be made on our feet, essentially? So, Roseanne, because you've spoken about the multi-sectoral space that you work in, we'll start with you.
Yeah, it was, of course, I think we've learned a huge amount about, this challenge, in fact, of the research and translating that into decisions, but with rapidity. And I mean, certainly from my perspective, from an actuarial perspective, the value of analytics as this data emerged was initially quite patchy data. So we had the problem of trying to draw conclusions from a little data. And then it actually became a lot of data. We had this vast volume of data and we had to sift from it what was important. And we had to be careful about issues of interpretation because of things like the prevalence of risk factors and so forth. So we had to really draw on the skill set in terms of dealing with data. But I think the biggest challenge perhaps that we all had was the questioning of science. And I think to some extent it took us all by surprise. This really quite vociferous questioning of science, that as data was emerging, as evidence was emerging from the data and the analytics, we had this situation where people were almost, I mean, even within my own profession, we had people sort of becoming attached to very strong positions that they had taken early on when there was limited data, and not being willing to shift from those positions. And those people, as I said, people within my profession, but also obviously the politicization that gave rise to, that as the data emerged, people were so unwilling to shift from those positions, and it became very politicized. I think the other thing is the extent to which social media messaging caused, again, that questioning of science and the sort of almost rejection of research and evidence. So to me, one of the things that we need to be thinking about as we emerge from COVID, obviously there are the health implications, but from a research and sort of scientific approach, is how do we address this kind of general lack of trust and the accusations of conflicts of interest that cause this kind of dismissal of fairly robust evidence, and how do we as research leaders or as those who are engaging with research leaders across various disciplines, I mean, how do we address that? And I think it's important that there does need to be this balance. I mean, we're always taught, right, as with curiosity, we should question everything. But we need to balance that, right? We need to question everything, but we need to trust something so that we can build on it, because that's the nature of research, is building knowledge, which then of course is what drives the solutions. So I think we do need to address the concerns of trust in our research institutions. And I mean, I think that's important, is for us as a scientific community to be building strong research institutions which have standards which are then relied upon, and that when those standards are met, that then the evidence is treated as valuable evidence, and we can avoid these accusations of conflict of interest. And then together with that, I think, and there were a number of people who, I guess, stand out through this period, who were really quite resilient to the conflict, to the critics who accused them of conflict. And perhaps that's also a skill that we need to develop in the researchers, as we've talked about mentoring and building the skill set. I remember it took me about 18 months to recover from my first journal rejection. The first time I submitted a paper to a journal that was rejected. And I think that building that resilience amongst researchers, resilience to be questioned, resilience to have these kind of unfair accusations thrown your way, and sort of that trust in yourself and your search for truth. And I think we've got some really great examples through COVID of leading lights in that regard.
Right. Any of the panelists wants to add to this lesson? Maybe Musa, you've got an award for communication in science for COVID?
Sure. Pumla, where to start? I don't even know how to synthesize, but I think I'd like to endorse the points that were made. Yeah, I want to endorse the points that were made by Rosea, and really, I think those are important. Maybe for clinician scientists, I think the point about what to do when we deal with a new problem, we are faced with a new problem. We saw it a little bit with HIV, but with COVID, it was on steroids. And how to navigate that, that's quite challenging. And I found myself having to go back to the basics, just learning, going back to virology, just learning the basics of the virus to understand that, and going back to immunology, understanding how the body responds. And, so in the context of limited information, you still have to take a position based on the evidence that you have in front of you. And that requires sort of quite an in-depth level of understanding. And I think sometimes we are shy as clinician scientists to go back there to the very basics, because we just want to rely on the knowledge that we already have. But we really have to open ourselves to just going back to the basics and learning once again, even things that we think are obvious. As Roseanne said, we need to question them and just learn again. That is the first thing. And I think the second thing that becomes important is to really think about how we navigate the scientific debate in the future. We cannot have scientific debates that are so normal for us to debate and contradict each other and look at opposing pieces of evidence. We cannot do that in the public as scientists, and especially as clinician scientists. It confuses the public and it fuels the kind of things that Roseanne has referred to. And scientific debate is healthy. We need that. It needs to be robust. But we need to find good spaces in which we can engage, even in the throes of a pandemic. And that's the part that I struggled with. And it is not nice for me as someone who had to communicate publicly to kind of get into disagreement with my peers and colleagues, people that I respect, and yet have to sort of publicly oppose their views. I didn't like that, but at times it needed to be done. The last point I just want to mention is, I know that we value conducting research and having primary data, but I think that we need to think about how to become comfortable with doing a rapid secondary analysis of existing data, so that we can produce evidence quickly, especially when there is pressure and the need for rapid turnaround. The second thing that I think is important is for us to be comfortable with synthesizing existing evidence. I think that, one of the things that was really important, and as Roseanne has said that as well, is that there is too much information. And for me, I spent so much time reading and synthesizing evidence and having to keep up with evidence all the time. And it evolved very quickly. So that aspect, I think, is very difficult. And it is then linked to learning how to communicate the synthesis of the evidence that you've done. Once you've synthesized it, then you have to, I suppose that's a third point to what I want to say. But I would say that those three things, the scientific debate, the synthesis of the evidence, and perhaps how to then package the messaging, it becomes really, really important. Thank you.
Great. Liesl, I see your hand is up, just briefly, and then we'll go to Keith.
Sure. I just want to echo what we've heard so far. I mean, really very positive and negative lessons from COVID. And I think the big thing, again, as we heard in the previous panel, is taking this into action now and saying, how do we implement and grow from those lessons, rather than say that was what happened during COVID. Now let's go back to, the past. Let's incorporate that into going forward. And I think the one thing I wanted to raise was the issue of pivoting, and pivoting rapidly, and pivoting effectively and efficiently. So one of the things, for example, is, a -80 fridge or -80 freezer often has various racks, and they each belong to different people, or they have a whole gap of space. And what we ended up doing during COVID was sharing those freezers, because we didn't have enough between us, and we filled them as groups. And that is something that is a very simple technique to actually bring the groups together doing different things, but to share our resources efficiently, and in doing so save money and accelerate the work that goes along with it. So I'm hoping that we are able to take those lessons and actually concretize them going forward, because that also spoke to this whole of society, whole of science approach to the COVID time. I think the other thing that we have to think about is, how do we do the pipeline of taking research ideas into products? And of course, the whole vaccine lesson is so key to the act that we were all doing it in silos before. It takes much longer, far more expensive, takes 15 years to get somewhere. We were able to do it in 15 months. How could we do that now? And what can we do with that going forward? And then a final point, just because I looked through the attendees and got lots of young people on this call, thank you, is the issue of mental health and wellness, and how that came through so strongly in our researchers, in our community over this time. People work day and night to get, the first J&J vaccine out there, etc., to get all that fantastic data out there. But it also brought into very stark reality how difficult that is. And so that's also something for the mentorship and the leadership, but growing new researchers, is also focusing on their wellness as well. Just wanted to make those points. Thanks, Puma.
Thanks, Liza. Keith, as the head of Health of Western Cape, what did you learn and what lessons are you taking forward?
The one thing I've learned is that we did incredibly well as a country, the one thing we taught ourselves, and because I'm a very strong proponent of understanding leadership and what it means for your own journey as relation to the team, as relation to a broader society and having an impact, is this notion of being adaptive. We have learned how adaptive we can be. COVID has, in a sense, given us the confidence, or should have given us the confidence, to say all the things, the wonderful things you heard from Roseanne, Mosa, and from Liesel, we could do that in a very short period of time. If you ask any one of us 3 years ago, 2018, and you give us a scenario, and you ask us, do you think you will be able to do this in a period of 12 months between March 2020 and December 21? None of us would have said, we have the confidence that even with our own journeys, that we will be able to pull this off collectively, because the mountain would have seemed so much bigger to us 3 years ago. We're sitting here now, we can look back at 18 months and say, yeah, what we've done is nothing short of miraculous. But I think Liesel's point is, we need to draw from it. Again, I would like to say, let's get common language. And for me, this speaks to the resilience and the adaptive nature of people in the South African context. I'm not saying people elsewhere is not resilient, they are not adaptive, but we have the ingredients here to shoot way above our, let's call it our, what we should be doing internationally. And not, as the first speaker said, that we are, as Africa, shooting way below what we should be doing. We have an opportunity here to lead the way. I would just say what was done with Tulio de Oliveira, what is done with the genomics has shown us the way. With that amount of resources and to lead the world in that way, that is such a shining example for us of how we should, what we should strive for. We shouldn't strive for, Liesel, definitely how we used to do things in 2019. We should strive for saying and showing the world what can be done in 2024, 2025. Thank you.
Thank you. I can't believe the time has run out so fast, but in one sentence or less, what would you say to an aspiring clinician scientist who wants to go into policy making? What advice would you give? One sentence or less, and then we can conclude. Liesel, you can go first.
Yeah, I would say this is your opportunity. This is how you make the impact. This is making impact at the core of everything you do. Think out of the box, preach to the others, not just the choir, and really utilize all of the people around you, not just your clinician scientists, all of the people around you to be able to do that. Keep the community at the core.
Roseanne?
Yeah, I would say just do it, but also be driven by your passion. So think about obviously the public interest and where the need is, but focus your energy on where your passion lies, because you will make the biggest difference if you're following your passion as opposed to thinking about what you should be doing or what others think you should be working on. So your research goals should be driven by your passion.
Musa?
Yeah, I would say that invest in building relationships of trust. That requires for you to also be trustworthy and therefore fulfill the attributes that Sir Tumani Corrah mentioned about research leadership. And if you do that, then you will be able to become trustworthy yourself, and you will benefit now later in the social capital that comes out of those relationships of trust.
And Dr. Kuti?
I'm going to use a short story. In February 2020, there was a new cohort of public health registrars that started in the system. When they started, they didn't know what was about to happen. My answer from the base of watching those registrars for the last 18 months I would just say for you, this is your time. Take it with both hands. Let's look back from 2040 and say, this is the period that shifted the trajectory of the needle in South Africa.
Right. It remains for me to thank you all for your perspectives on translating research into policy. I'll hand back over to Lerato to introduce our vote of thanks speaker.
Thank you so much for that meaningful discussion. I think all of us have gleaned so much from just both of today's panels and are equally encouraged and inspired about the opportunity we have as upcoming clinician scientists, but also as a community of clinician scientists who are paving the way for people to come. We are definitely fast running out of time, so I'm going to hand over to Nomathemba Chandiwana to close today's session for us. Thank you so much for your time and attention.
Thank you so much, Lerato, and thank you all for attending such a wonderful and thought-provoking session on leadership in our context. And I would like to thank all the distinguished panelists. This was an incredible morning. You know, it was chilly for a lot of us getting up on a Saturday, but it was well worth it. And also to hear from the leaders that are here with us today and pushing the needle on leadership. And the concluding remarks have actually been done. You know, if I would say the last speakers in particular took all, summarize what I would have wanted to say about it so well that I would not want to repeat it further. But let me end by saying that no man or woman can make a great leader if they want to do it all by themselves. They have to do it together. And let this be a call to action that we've been through. We've seen the positive aspects of leadership and also the difficulties of leadership where we are in South Africa in clinical medicine and research. And as we go into the next phase, which is really also quite challenging in some respects, let's do it together. I would like to thank all the people who made today possible. Would like to thank people from our keynote speaker, the incredible panel of panelists, our moderators, our program directors, and all the people behind the scenes, including the IT team. I'd also like to acknowledge the wide representation across all the medical schools in the country, the deans and the leadership in attendance. Thank you all and have a good afternoon.